ESPAUR report webinar for 2022, providing data from 2021 to 2022. I'm only going to start with a very brief welcome and introduction in the context of housekeeping. So next slide. My name is Diane Ashirodokwe. I'm the lead pharmacist for antimicrobial resistance at UK Health Security Agency, and I'm also the chair of ESPAUR. So just a few pointers for you to please remain on mute. So when you arrived, you'll be on mute and cameras are off. Please feel free to tweet using the hashtags ESPAUR, Antibiotic Guardian, Keep Antibiotics Working, and WAW 2022. So there's a range of tweets there. We would love for you to share this broader with your with those who follow you on social media, and also with colleagues as well through other means. We'll have an introduction from Professor Susan Hopkins shortly, and then we'll go through the various chapters within the report. The context is that we will present very brief data from the report. As you will have seen, the report is quite long, and there's several pages of them, more than 200 pages. But actually what we want to do is to give you a flavour of what's within each chapter, and then you can go into those chapters and read more about it and share the information. In between, we'll have Q&As. A key point, though, is to highlight that all questions should go in the chat. Next slide, please, Ella. All questions should go in the chat, and what we'll do is colleagues will answer those questions as they come up in the chat or once they finish their presentation, and then we may take some of those verbally. We will reply to them verbally, but we won't be able to give opportunities for those who are on the call to answer questions because we've got very short and limited time to get through. We're not going to be presenting the methods today. All of that is within the report, and all the data, we're not presenting all the data. Again, full details within the report. We would love your feedback. The reason we are doing this for the second year is because we were asked to, and there was feedback to ask us to do this from last year. It's great to have almost 288 people registered from all over England and actually all over the UK as well. And we also have some colleagues from outside the UK who have registered as well. So warm welcome. And it's great that we've actually got more than 50% of those who have registered on the call, because usually for most webinars, fewer people turn up live. We will make the recording and slide sets available to all who have registered on the Antibiotic Guardian website, and we'll do that once we have the feedback back from colleagues. That's an easy way for us to be able to send that through to colleagues. Next slide, please. Thank you. We're going to start. We want to thank people in advance because none of what we do will be possible without huge collaboration across our own organisation, UK Health Security Agency, but also several national organisations who are part of ESPAUR, and there are more than 23 national organisations who form members of the ESPAUR Oversight Group. Also colleagues from the devolved administrations and learned bodies as well. So we're really, really grateful for the support from all members of the ESPAUR Oversight Group. We cannot do this without you. Next slide. And also the report itself, you can see there, we do not expect you to read this slide, but it shows you the number of people that are involved. And I think we have more than 100 authors, is that right, Ella, who contribute to this. And we have chapter leads, 1 or 2 chapter leads per chapter who lead on putting together the reports. But it's huge amount of work from so many colleagues. I want to make special mention for Ella, who's our project manager, who makes sure that we keep to time and we follow the timelines and to be able to deliver the report. It's a huge amount of work, and I'm very grateful to her. Also to Carrie and to Ellie, who has stepped in over time to support that. The whole of the AMR program team as well. It's a great team that I'm part of who make all of this possible. And so for that, I am personally grateful. I'm going to hand over now to Susan. Thank you so much.
Sorry, Susan, I think you're on mute.
Thank you, Ella. What would we do without you? So hello, everyone. My name's Susan Hopkins. I'm the Chief Medical Advisor in UK Health Security Agency. And prior to the pandemic, the work on antimicrobial resistance was the main thing that focused my efforts and did lots of work on for the previous 10 to 15 years. And the English surveillance programme for antimicrobial utilisation and resistance was the baby of Diane and myself in 2013, along with many others on the call, and also Birgit Müller-Peppedy, who was alongside us doing the initial epidemiological analysis with many of her team. Over the years, it's grown in size and grown in volume and grown in collaborators, which says a sign of a good thing. The oversight group, which has 23 different organisations represented on it, have continued to attend the meetings. And Diane formally took over as the chair when the pandemic diverted me to other pathogens. The oversight group is a multi-professional group. It has representation from the devolved administrations, from the NHS, from multiple professional societies, stakeholder organisations, and also lay public representation. That allows us to really have good views into what we're doing. Is it the right thing? Is it what people need? And you can see from the volume and depth of this report how much effort goes into it from a very wide range of individuals and organisations to contribute to it. This is the 9th report, and there are some good news in this 9th report and some news that's perhaps not so good. The first thing I would say is that antibiotic use has reduced in this country over the last 8 years, since the peak of 2014, which was the year of the first report, by almost 20%. Now, that in itself deserves a round of applause for all of you healthcare practitioners and prescribers that are on this call, because it is every effort by all of you that is making that difference. It accelerated during the pandemic, no doubt due to differences in healthcare behaviour, health-seeking behaviour and healthcare delivery. And we already are seeing that in 2022, there are rises in the amount of antibiotics that are being used. So it will take some time to settle into what is the post-pandemic antibiotic use that we have. But no doubt, this is still a positive achievement, and a lot of it is in the right direction. But there is more work to be done, and more work to be done by you and by us in trying to achieve our agenda of only prescribing antibiotics when we need them to the individuals who need them, facilitated by the right diagnostics, the right tools that allow you all to do that in the best possible way. In terms of antimicrobial resistance, and you'll hear lots more about this in the report, the news doesn't look as good, but I was trying to explain this to colleagues that we should be looking at antimicrobial resistance in the same way as we look at climate change. This is a wicked problem. It's going to need lots of effort and attention by not just us, clinicians, epidemiologists, public health physicians, healthcare practitioners, nurses, pharmacists, and many other individuals. It also needs the will of government. It needs the will of the people, and it needs the will of industry in order to tackle new diagnostics and new antimicrobials so that this becomes less of a threat in the future. It is all of those things together that we're here working on today. And I think, again, in terms of looking back and reflecting on climate change, staying steady, making some small reductions, not accelerating antimicrobial resistance is a positive impact. We know, for example, the rises that we saw in extended spectrum beta-lactamases reflected as third-generation cephalosporin resistance was pretty dramatic in the previous 10 to 15 years. That's now remaining very stable, not necessarily the exact same from one year to the next. Some years it goes up, some years it goes down, some years it doesn't change. But that is a dramatic improvement on where we could have been. It is also a dramatic improvement when you see the amount of carbapenemase infections that are in this report, carbapenems being the antibiotics of last resort that we have for the majority of gram-negative infections. And without all of your efforts, we could be in a much worse place. Some parts of Europe are reporting very high levels of carbapenem resistance, and that is really meaning that individuals with these infections have very little options remaining, and increased amounts of those individuals die. So my view here today is that this is an optimistic report, but I think that we will need to see the full post-pandemic effect before we see the effect of the pandemic on our prescribing, on our resistance, on changes in individuals' behaviour, both in the public and in professionals, and that we have a lot of work to do together. So thank you for coming together today to hear what is going to be a fantastic presentations from the team. Thank you to all of you who are delivering the presentations for your great work over the last year, and I look forward to seeing many of you in future meetings.
Thank you very much, Susan. Really grateful for that. Colleagues, if you've got questions, please put them in the chat and Susan will be able to reply to some of them, but she, as you can imagine, will need to go off to other meetings. We're very grateful to have some of her time. Lots of appreciation for you there, Susan. Thank you. Okay, next slide, please. We're going to move very swiftly on to chapter 2 of the report, which is on antimicrobial resistance. And I'm going to invite Kirsty Bennett to present this on behalf of the team.
Thank you, Diane, and good afternoon, everybody. My name's Kirsty Bennett, and I'm a scientist in UKHSA's Antimicrobial Resistance and Prescribing team. And I'll be talking through some of the highlights from Chapter 2 of the ESPAUR report, which covers antimicrobial resistance, or AMR. This year, the chapter includes key indicators on antimicrobial resistance in bacteria, a section on acquired carbapenemase-producing gram-negative bacteria, antifungal and antiviral resistance, as well as some other sections such as foodborne bacteria and sexually transmitted infections. I won't have time to go through all of these in the presentation, so I would just urge you to read the chapter for more detail. Next slide, please. So moving on to the first key point from the chapter, this is one of our infographics, and this shows the AMR burden of bloodstream infections. So AMR burden is an aggregated indicator of the number of infections that are resistant to a key treatment antibiotic. It combines a number of different species and key treatment antibiotics to give an estimate of the number of incidents and the number of resistant infections being seen year on year. The calculation ensures that each infection report is not counted in any subsequent antibiotic combinations and avoids double counting, but more details on this calculation are available in the methods annex. So the red graph shows the overall number of key pathogen bloodstream infections, and the blue graph shows the number of resistant key pathogen bloodstream infections. For both of these indicators, there was a 4% decrease between 2017 and 2021. However, prior to the COVID-19 pandemic, so between 2017 and 2019, these indicators were both rising. So this means that 19 out of every 100 people with a key pathogen bloodstream infection had a resistant infection in 2021. However, there was key regional variation. Next slide, please. This infographic shows that regional variation in AMR burden. So the blue map shows the incidence of key pathogen bloodstream infections in England in 2021, and this was the highest in the northeast. The red map shows the rate of the estimated burden of antimicrobial resistant bloodstream infections, and comparatively this was highest in London, followed by the northwest and the southeast. And this is likely due to a combination of factors, including population density and the location of specialist treatment centres. Next slide, please. So looking now at the species that are causing AMR burden, the bar graph on the left shows the overall AMR burden for total bacterial bloodstream infections for 2021, and the pie chart shows that 47% of these were E. coli. However, looking only at the antibiotic resistant subset of these bloodstream infections, which is shown by the smaller blue section of the graph, a larger percentage of these, almost 2/3, were due to E. coli. So this shows where the bulk of the burden of resistance lies. Next slide, please. So this graph shows the incidence for key pathogen bloodstream infections from 2017 to 2021. For many of the key pathogens, such as Klebsiella pneumoniae, Pseudomonas species, Acinetobacter species, and Enterococcus species, the incidence of bloodstream infections showed a slight increase between 2017 and 2021. However, looking at E. coli bloodstream infections, in 2020 and 2021, the incidence of E. coli bloodstream infections decreased. And this explains why we saw earlier that there's been a decline in the overall burden of antimicrobial resistance in 2020 and 2021, as this has been predominantly driven by the reduction in the incidence of E. coli bloodstream infections. And this itself is likely due to the multifactorial effects of the COVID-19 pandemic, which commenced in early 2020. Next slide, please. This infographic shows the percentage of patients with different types of gram-negative bloodstream infections that have died within 30 days. So overall, for any gram-negative bloodstream infection, the 30-day all-cause mortality was 16.5% of patients. Patients infected with a gram-negative strain resistant to one or more key antibiotics had a higher case fatality rate, 18.1%, compared to those with an antibiotic-susceptible strain at 16.3%. For carbapenemase-producing gram-negative bacteria, and these are bacteria that can produce hydrolyzing enzymes that confer resistance to carbapenem antibiotics, the 30-day all-cause mortality was even higher at 24.5%. However, the total number of invasive carbapenemase-producing gram-negative bacteria was low. Next slide, please. Looking in more detail at the carbapenemase-producing gram-negative bacteria, this graph shows the rate of these bacteria infections by indices of multiple deprivation decile, and this is for all specimens, not just invasive specimens. So on the graph, 1 represents the most deprived decile and 10 is the least deprived decile. And you can see that the general trend is that the more deprived a decile, the higher the rate of carbapenemase producing gram-negative bacterial infection per 100,000 population. Next slide, please. So this is again for carbapenemase producing gram-negative bacteria. And we can see that as well as these differences by social deprivation status, there was also a great deal of variation in the frequency and the region that the big 5 carbapenemase families are being reported from. And these big 5 carbapenemase families are IMP, KPC, NDM, OXA48-like, and VIM. So each map shows the rate per 100,000 population of acquired carbapenemase producing gram-negative bacteria for each of the big 5 carbapenemase families. The Northwest had the highest rate of KPC notifications, as shown by the pink map in the top row, and London had the highest rate of NDM notifications, as shown by the teal map in the top right-hand corner. In comparison, the OXA48-like carbapenemase family notification rate was highest in the West Midlands, as you can see on the yellow map. Next slide, please. So this slide focuses on antifungal resistance, as AMR is not just about bacteria. So the incidence of candidemia has increased by 9.7% since 2017. The bar graph shows that for the majority of candidemia, resistance to key antifungals remains low, and this is particularly to Candida albicans, as shown by the middle section of the bar graph. And this is important because, as shown in the pie chart, Candida albicans was the most frequently isolated singular Candida species across 2021, accounting for 43%. Next slide, please. So what this all means, as outlined in the presentation, the impacts during the COVID-19 pandemic and the residual impact, such as changes in healthcare use, have the potential to mask longer-term trends, particularly as this data set is for 2021 data, which is when there were elevated COVID-19 cases early in the year. The regional differences that I spoke through highlight the importance of local decision-making and data availability. This is the first year where we've started to look at health inequalities. We've looked at deprivation and also included some early ethnicity analysis in the report, both of which saw variation, but we're going to focus on building these in future work streams. Next slide, please. So yeah, this slide highlights a few of the key areas for future work. For more detail, please do see this year's report as well as next year's. So key focus areas for the next year include integrating phenotypic and genotypic data on carbapenemase producing gram-negative bacteria derived from local testing into SGSS, and enhancing our data by linking to hospital episode information to include patient-level clinical, epidemiological, and risk factor data. As I mentioned previously, the report touches on ethnicity and deprivation, but future work, including a carbapenemase-producing specific detailed analysis, will investigate these in more detail. Next slide, please. And since this presentation has just been a whistle-stop tour of the chapter, these are some of the additional topics that are available in the full chapter. And full data and figures are also available in the appendices, as well as more detail on the methods and the caveats. Next slide, please. So this is just to acknowledge all the people on this slide. The writing of the ESPAUR report is a huge team effort. So thank you to everyone who is listed here. And finally, thank you very much to everyone for listening. Looking forward to some of the questions in the Q&A section.
Thank you so much, Kirsty. We're going to move straight in now to antimicrobial consumption, which will be presented by Holly. You can see lots of claps for you there, Kirsty. Over to you, Holly, on behalf of the Chapter 3 collaborators.
Hi, thanks, Diane. So hello, everyone. My name's Holly, and I'm a scientist in the Antimicrobial Resistance and Prescribing team as well. And today I'm going to present on Chapter 3 of the ESPAUR report, which focuses on antimicrobial consumption. Next slide, please. So Chapter 3 of the report works to highlight the need for antimicrobial usage surveillance and information for action to inform progression towards the UK's National Action Plan ambition of reducing total UK antimicrobial consumption in humans by 15% by 2024. It demonstrates the importance of monitoring trends over different settings and especially over time, with trends pre-COVID-19 pandemic as well as during and post-national restrictions shown. In this webinar, I shall give an overview of some of the data presented in this chapter, first focusing on antibiotic consumption, going through total consumption and then broken down to look at consumption in primary care and then secondary care, before moving on to a quick overview of antifungal consumption. Next slide, please. So beginning with total antibiotic consumption, so over the last 5 years, consumption of antibiotics as DDDs per 1,000 inhabitants per day, also known as DIDs, has decreased by 15.1% across England from 18.8 to 15.9 DDDs per 1,000 inhabitants per day. However, as we can see in this figure on the left, whilst the rate was decreasing from 2017 to 2019, the decrease was very much accelerated in 2020, coinciding with the start of the COVID-19 pandemic. Between 2020 and 2021, there was then only a 0.5% reduction in DIDs, and interim 2022 data suggests the trend is increasing towards 2019 levels again. Antibiotic prescribing in 2021 continued to mostly occur in general practices, as you can see in the figure on the right, with GPs seeing 72% of total prescribing, accounting for 11.5 DIDs. Hospital inpatients then saw the next highest percentage of the total at 13% and 2.1 DIDs. Next slide, please. So this is just giving a look geographically at the different UK HSA centres. So we can see whilst there are evident regional differences between the centres, the regions do tend to follow the same trend at the same time. So for example, they all show a decrease in total DIDs between 2019 and 2020. The Northeast has consistently been the region with the highest total and primary care prescribing for the last 5 years, with London having the lowest. And then conversely, London has had the highest prescribing in the secondary care setting. Next slide, please. So looking just at primary care, we can see that antibiotic consumption has declined over the last 5 years, measured as items per 1,000 inhabitants per day. So it's declined from 1.8 items per 1,000 inhabitants per day in 2017 to 1.49 in 2021, which represents a decrease of 17.2%. There was a substantial decline between 2019 and 2020 with the start of the COVID-19 pandemic period, seeing an 11.1% decrease in the 1 year alone from 1.66 to 1.48 items per 1,000 inhabitants per day. And then between 2020 and 2021, there's then a slight increase of 0.6%, although this in 2021 prescribing was still below the preceding 3 years pre-COVID-19 rates. Next slide, please. Analysis looking specifically at broad spectrum antibiotics in primary care was conducted. So similar to total prescribing, there were decreases in prescribing seen from 2017 to 2021. And then there has also been decreases in broad spectrum antibiotics as a percentage of total antibiotics. There was, however, a bigger decline in prescribing from 2019 to 2020 in broad spectrum antibiotics, with broad spectrum seeing a 19.8% decrease from 0.59 to 0.48 items per 1,000 inhabitants per day, whilst total antibiotics only decreased by 11.1%, as already mentioned. And then, as you can see in the graph, looking from 2020 to 2021, broad spectrum subsequently saw a slightly bigger increase. So they increased by 5.6% versus the 0.6% that total antibiotics saw. For both total antibiotics and broad spectrum antibiotics, prescribing rate is still below 2019 levels though. Next slide, please. So dentistry was the only setting, so primary and secondary care, where prescribing rate increased between 2019 and 2020. Specifically, increases were mostly evident in amoxicillin and oral metronidazole use. Antibiotic items prescribed in dental care have reduced since 2020, the 2020 increase, as we can see in this figure on the slide. It hasn't reduced below the immediate pre-pandemic levels that were seen in 2019, although it is slightly below where it was in 2017. Next slide, please. So moving on to secondary care now, we can see that antibiotic consumption has decreased in 2021. This is now measured as DDDs per 1,000 admissions. And it's decreased from 2020, but it's also decreased below pre-pandemic levels. So from 2017 to 2019, there was not much change in prescribing year on year. The pandemic then saw this increase in 2020 before the decrease in 2021. The initial increase in 2020 masked a reduction in total DDDs prescribed, which reduced by 18%, and then with a greater decrease seen also in hospital admissions, which decreased by 22% between 2019 and 2020. Similarly, the 2021 reduction in rate from 2020 is more reflective of an increase in the hospital admissions denominator, which increased by 13.4%, whilst DDDs only increased by 1.5%. Next slide, please. So in 2017, the World Health Organization classified the essential medicine list key antibiotics into 3 categories known as the AWARE categorization. So this was to improve access to antibiotics, creating the access group, to monitor important antibiotics, which became the watch group, and then to preserve last resort broad spectrum antibiotics, which are those found in the reserve group. To keep as many bacterial infections susceptible to treatment with antibiotics as possible, the access category should be the category with the highest percentage of antibiotics prescribed. And using a version of these categories adapted to fit the antibiotic landscape in England, we can see that this was the case in 2021, with 51.3% of all antibiotics prescribed in secondary care being access antibiotics, followed then by the watch group, of which 45.3% of all antibiotics were watch antibiotics, and then 3.1% were reserve. Next slide, please. So just a quick look then at antifungal consumption. So prescribing in primary care, which is the graph on the top left, similar to antibiotics, decreased from 2017 to 2021 by 25.4% from 1.2 to 0.9 DDDs per 1,000 inhabitants per day. Again, the biggest decline was between 2019 and 2020 with the start of the COVID-19 pandemic period. And consumption then increased by 6.9% from 2020 to 2021, although again, this is still below pre-pandemic levels. Consumption in secondary care as DDDs per 1,000 admissions has increased from 2017 to 2021. So it's a 7.1% increase, and you can kind of see this in the graph on the bottom right. And this has increased from 178 to 191 DDDs per 1,000 admissions. Consumption is still raised above pre-pandemic levels in acute trusts, but there was a decrease from 2020 to 2021 by 4.5%. Next slide, please. So then just looking at some of the regional differences in 2021 in between, well, across England and also in between antibiotic and antifungal consumption. So in 2021, antifungal consumption, which can be seen in the figure on the right in the blue map, was highest in the northwest with 1.37 DDDs per 1,000 inhabitants per day, and then lowest in the east of England with 0.81 DIDs seen. Whereas for antibiotics, consumption was then highest in the northeast with 18.3 DIDs, although northwest was a close second with 17.5 DIDs, and London had the lowest prescribing, seeing 13.3 DIDs per 1,000 inhabitants per day prescribed. Next slide, please. So just looking at some of the implications of the data presented in this chapter, as has been shown in the data presented, COVID-19 has still been impacting antimicrobial consumption in 2021, with total prescribing rate as DIDs still decreased from pre-pandemic levels. There are many factors that affected prescribing needs and behaviours as a result of the COVID-19 pandemic, including social restrictions encouraged through national and regional lockdown measures, and then changes in the case mix of patients who were consulting in primary care, as well as those who are admitted into hospitals, with delayed and cancelled elective procedures and increases in more acutely ill patients and increases in admissions to intensive care and high dependency units seen. So these and other factors led to the changes seen in prescribing over the last 2 years, particularly in 2020. With services beginning to resume, consumption trends are somewhat changing to reflect this in 2021, with slight increases or decreases back towards trends pre-pandemic levels being seen. It will now be important to keep emphasising appropriate prescribing to keep the rate at these lower levels observed. And then regional differences in antimicrobial use are also seen, which has been highlighted in this presentation, with differences seen in use by prescriber setting per region too. This has implications for stewardship and highlights the importance of surveillance in better understanding trends and improving stewardship. Next slide, please. So from all this work that's been gone on in the chapter, future actions have come about, with some of these highlighted on this slide here. So important future actions include accessing other data sets such as patient level and the unified infection data set to be able to get more complete information on prescribing practices and allow for more in-depth analysis. Also assessing the impact of changes in consumption, such as the impact that COVID-19 had on dental prescribing, and assessing any potential unintended consequences from the changes in antibiotic use in England will be important to research. Next slide, please. Finally, this presentation only gave an overview of the main topics covered in Chapter 3. Further information and materials are available online, including further results and discussion, such as antiviral, specifically hepatitis C, and antimalarial usage trends, full data tables and figures appendices, and then methods and caveats annex, which details like the data sources, analysis and caveats, and also contains supplementary results as well. Next slide, please. I think that should be all. Thank you very much for listening, and thank you to everyone who helped contribute to the writing and analysis of the data in this chapter.
Thank you, Ollie. We're going to move, lots of appreciation for you there, thank you. And we're going to move on now to Antimicrobial Stewardship chapter, which is the chapter that I'm leading on, but again, could not be possible without significant input from several colleagues, particularly the Primary Care and Interventions Unit, with Catherine and Donna and other colleagues, and Ella really taking on an honorary lead role for helping to coordinate the chapter as well. Next slide, please. So within this chapter, as you can see also that we had collaboration from NHS England on this chapter, so grateful for that. This chapter will take us through our antimicrobial stewardship interventions that we developed nationally and just share some of those findings as well as some results that we had available. Most of us on the call will know that tackling antimicrobial resistance requires a multi-pronged approach, and optimizing antimicrobial use is one of those. And this is where we really focus attention within here is what interventions are we developing or have we developed in collaboration with others to help us to help support colleagues who are on the front line who are prescribing to patients in optimizing prescribing for antimicrobials. And it's definitely one of the key focus areas for the National Action Plan. And it will help us to be able to get to that target to reduce antimicrobial use in humans by 15%. I know that we are there's the data showing great improvement that we've made, but it's really important that we continue to take action, because as you will see within the report as well, we're already seeing some resistance to new antimicrobials. Next slide, please. So I'm going to go very quickly to the Target Antibiotics Toolkit. Many of you will know that that is the national toolkit for primary care. And the toolkit over the year underwent a major redesign and went live during November of 2021, including new sections within that to provide evidence-based resources and to support clinicians to discuss antibiotic use with their patients. Also within that was the patient information leaflets, which were redesigned and redeveloped as accessible websites and web pages, as well as integrated into Accuric's free healthcare communication service, so that they can be easily shared during remote consultations. You can see there a range of webinars were also developed and delivered during that time. Next slide, please. The toolkit has a range of resources, and I just wanted to talk you through some of that. So there are webinars and podcasts, and colleagues within PCIU in collaboration with other colleagues are continuously innovating and providing new resources to ensure that we meet the needs of clinicians. There are self-assessment toolkits, audit toolkits, and I think our most popular one, and we've been told that all through COVID, this part of the RCGP website, the Target toolkit, was the most accessed even during COVID. Leaflets to discuss with patients. One of the great things with the leaflets from Target is that they're also available in multiple languages as well. Next slide. The antibiotic checklist is one of the resources available through the Target website, and I'm going to just talk very briefly about it from a context of the implementation and delivery, and then Dr. Kieran Hand will talk a little bit more around the policy implementation and implication from the checklist, which we worked with in collaboration with NHS England colleagues. So the Target Antibiotic Checklist supports community pharmacy colleagues in their stewardship activities, and the idea with it's slightly different to the treating your infection leaflets. This is when a patient comes in with a prescription for an antibiotic, and what are the key approaches that community pharmacy teams should go through. And then working alongside NHS England, that became part of the pharmacy quality scheme. And what that allowed was for implementation of this tool across community pharmacy. And it was great to see significant contribution from the community pharmacy teams. I don't want to give away the exact numbers that participated. I know you can see some of that on the slide there, but Dr. Kieran will go through that in more detail. And you can see there we were able to get some clinical data as well, which we are currently analysing and will be really important to share information on patients who have come into the pharmacy, what their knowledge is, what doses and doses, and what pharmacists were discussing with doctors as a result of those prescriptions. So that's some of the data we have available, and I've shared the preliminary data within the ESPAUR report. Next slide, please. We also developed, so one of the key asks that we have, and actually this is in the National Action Plan as an objective, is supporting primary care clinicians, specifies pharmacists within the National Action Plan. But when we started to develop this, and led by a clinical fellow who was working with me at UKHSA, Ellie Harvey, what we were told was that actually this should be for the whole primary care team. And so this was developed to support primary care teams to review the dose and duration of long-term and repeated courses of antibiotics. So patients who are coming back for repeated courses of antibiotics, or who are on long-term prophylaxis of antibiotics. And in the first instance, we focused on acne and COPD, and we did some work with RX Info, and as well as, sorry, we did some work with, I'm confusing myself, with Open Safely, rather than RX Info, who focus in secondary care, Open Safely, to look at the primary care data. And we were able to identify that acne, COPD and UTI were common infections where there were long-term and repeated antibiotics. And so we've started with acne and COPD, and colleagues within NHS England are working on the UTI how-to guides as well at the moment. Next slide. This is also really linked to the structured medication reviews and DES. For those who are within the pharmacy world, you'll understand what we mean by those as well. For secondary care, we developed a national criteria for intravenous to oral switch, and we did this in collaboration with 279 colleagues across all 4 UK nations. And you can see there was a 4-stage Delphi process that was used for that, and really important for us to make sure that we worked with colleagues to come up with this criteria. In addition to the criteria, we also have a decision aid that can support colleagues as they need to go through the process of switching patients in a timely manner from intravenous to oral. Again, that's in the initial findings are in the report. The criteria is now published, and the decision aid will be published in the next week or so. Next slide, please. Within within the division within UK, I should say, and actually across the nation, tackling health inequalities, as we know, is really important. And we have been working to try and embed a systemic approach to reducing health inequalities within antimicrobial resistance, at least making sure that we understand what data is available. And we went through a 3-stage process. First of all, understanding our divisional needs, where were the key gaps that we had within those who are working on antimicrobial resistance data and within the division as part of the ESPAUR process. And you can see there that the gap was around trying to understanding, training, resources, and also data. And so we were able to identify that, and we've been working with colleagues to develop that further. We also undertook 2 scoping reviews, and I'll talk about that shortly. And we identified what strengths we already had available. And some of that were around the resources that are published and developed through the organization, in terms of, for example, translating those resources where they're for the public into multiple languages, making sure that they're accessible. And by that, we mean easy read, for example. Also, even making sure that the way the reports, the ESPAUR report is an example of that. We're constantly working with our publishing team to make sure that it is accessible for those who may have color blindness or any other disability, so that we're not producing a report that is not as accessible for colleagues. And we also, within some of our majority of our resources, we ensure that there's a diversity of characters used as a representation within them. We also now have key performance indicators that we've committed to, and part of that is that our reports will always include data on factors commonly known to be associated with health inequalities. So you'll notice that within the ESPAUR reports, we've really increased that. And so Kirsty presented some of that, for example, with the CPE data, and that we're going to continue to do that over the coming months and years. Next slide, please. So from the scoping review, which was undertaken to really investigate the association between the elements commonly known to be associated with health inequalities and then the risk of antibiotic-resistant infections and antimicrobial prescribing in high-income countries. And there was evidence that ethnicity, income inequality, and deprivation status can increase the risk of suffering of having antibiotic-resistant infections. There's also association between factors known to be commonly associated with health inequalities and prescribing of antibiotics within high-income countries. For each health inequality factor, though, the extent of association varied between healthcare settings, the indications, and also the actual antimicrobial that is in use. One of the key things we highlighted also is that within the UK, there's a gap in the data that we are publishing. So there's work being done there to encourage more sharing of data so that we can really understand where the challenges are, and then we can develop relevant interventions for that. Again, the keep antibiotics working materials, for example, have now been translated into 12 languages, and that is available through the World Antimicrobial Awareness Week toolkit. So again, next slide, please. Very whistle stop to the antimicrobial stewardship chapter, just to give you a flavour of some of what is within the chapter. We continue to develop stewardship strategies across the healthcare sectors to tackle antimicrobial resistance. The Target Antibiotics Toolkit website, as I said, has been refreshed with new resources. We have developed how-to guides for primary care clinicians actions to review patients on long-term and repeated prescribing within acne and COPD. UTI is currently in development and is coming soon. And then within secondary care, the national IV Total Switch criteria is an important one that has been published, and we are going to publish the tool in the next couple of weeks, and we're really looking forward to implementing and also then getting feedback with those tools so that we can further develop them as required. I'm going to hand over now to Kieran Hand, who is going to present on NHS England's improvement and assurance schemes. And again, you'll be able to see how that how policy and these assurance schemes are really important to our delivery of the National Action Plan, and as well as tackling antimicrobial resistance. Over to you, Kieran. Thank you.
Thank you, Diane, and lots of acknowledgements for your hard work and the work of your team on the AMS initiatives. So as Diane mentioned, I'm going to be covering the NHS England improvement and assurance schemes that were live during the year of the 21-22 ESPAUR report. And my name's Kieran Hand, and I'm the National Clinical Lead for Pharmacy and Prescribing in the AMR programme in NHS England. And as with all of the other chapters, none of this would be possible without a team effort, and I'm extremely grateful to my colleagues in NHS England, including the primary care pharmacy team, as well as the AMR programme, and also working in partnership with colleagues in UK Health Security Agency. Next slide, please, Alan. Just a quick reminder of the policy mandate that we work towards. So the UK National Action Plan, the current National Action Plan runs until March 2024, and the high-level ambitions for antimicrobial prescribing are to reduce antimicrobial prescribing in primary care by 25% from a 2013 baseline. And the focus for hospitals is to reduce antibiotics from the WHO reserve and watch categories by 10% from a baseline of 2017. Next slide, please, Ella. Starting first with primary care, the oversight framework was described as the system oversight framework when the NHS began to move towards system working with the creation of integrated care systems from July of this year. And the system oversight framework, or the SOF as we call it, replaced the previous NHS oversight framework. And two important metrics were retained in the system oversight framework, which were the metrics for total antibiotic prescribing in primary care and the proportion of those antibiotics that were broad spectrum agents. And it wasn't guaranteed that those metrics would be carried forward in the oversight framework. So we were grateful to the oversight framework team and NHS England for continuing to support AMR as a high priority. So those two metrics were carried forward. What did change for the year 21-22 was to redefine the target for total antibiotic prescribing, and it's highlighted in yellow there. So looking across to the table, the first target being SO44A was total prescribing, and the target was aligned to the National Action Plan goal by setting it at or less than 0.871 prescription items per star PU, which is per patient adjusted for age and sex. Now, the previous target that had been deployed had been to aim for at or less than 0.965 from a baseline in 2013 of 1.161. And the 0.871 target now aligns to the National Action Plan target of reducing prescribing by 25% from that 2013 baseline. The target for broad spectrum prescribing remained the same, with a goal of keeping broad spectrums to at or less than 10% of all prescribed items. Next slide, please, Ella. This is a bit of a busy slide. I'm very grateful to colleagues in the NHS Business Services Authority for providing the data to us, and the data are reported on Future NHS. And these data come from the EPAC2 system, where prescription items are captured and reported. And you can see the top chart represents the first prescribing indicator for primary care, which is total items per star PU. And the bottom chart represents the proportion of those items that are broad spectrum. Now, focusing on the top chart, the green bars represent integrated care boards that met the target to reduce prescribing and it's reported monthly. So you can see that early in the year, from April 21, almost all of the ICBs, 40 or 42 ICBs, were meeting the national target to reduce total prescribing, and that declined over time. But by March 2022, so the end of the year for the ESPAUR report, 50% of the integrated care system, the ICBs, had at that point were meeting the NAP reduction target. And looking at the bottom chart again, the green bars represent ICBs that had met the target to keep broad spectrum antibiotic prescribing at or less than 10%. And that improved over time, and by the end of March 22, 84%, so 35 of the 42 ICBs had met that target to keep the proportion at or below 10%. And then it's worth pointing out that 17 of the ICBs met both targets, and that's almost half of ICBs. And often a challenge is put to us that it's very difficult to reduce both total consumption of antibiotics and also keep that proportion at or below 10% for broad spectrum. So for 17 ICBs, they did achieve that by the end of 2022, of 21-22. But it's clear from those charts that that whilst performance has improved on the bottom chart for proportion broad spectrum, performance in terms of total items prescribed per star PU has deteriorated during the final months of the year, and I'll explain more recent data towards the end of the presentation. Next slide, please, Ellen. Coming on now to community pharmacy, and as Diane mentioned earlier, NHS England introduced or is in the middle of a 5-year scheme for community pharmacy that includes an incentive called the Pharmacy Quality Scheme. And the scheme that was running during the period of time for this ESPAUR report ran from September last year until March 22, and it incentivized community pharmacy teams to use the antibiotic checklist, and an image of the checklist is presented here on the bottom left of the slide. And this checklist was used by pharmacy teams with patients who presented with a prescription for an antibiotic. So the patient had already been prescribed an antibiotic by a GP or non-medical prescriber, and the pharmacy team was using the checklist to counsel the patient on the appropriate use of those antibiotics, and following the instructions from the prescriber, and anticipating things like side effects, and advising patients not to share antibiotics with family or friends, and to return unused antibiotics to the community pharmacy for disposal. And the Pharmacy Quality Scheme, the details of the scheme are available on the NHS England website. But we were very pleased to see this is a voluntary scheme, but almost 3/4 of the over 11,000 community pharmacies in England participated in the scheme. And checklists were deployed in over 200,000 cases. And I'm very grateful in particular to Sejal Parekh, a pharmacist in the primary care team in NHS England, who's really spearheaded this PQS work. And that number of over 200,000 counselling events, the significance is that patients are becoming more aware of antimicrobial resistance and the importance of appropriate use of antibiotics, and hopefully this cascades awareness and learning throughout communities and through families and networks of families and friends as well. Next slide, please. Moving now to secondary care, and one of our major policy incentives or improvement and assurance schemes that apply to secondary care is the NHS standard contract. And the table sets out the standard contract targets relevant to antimicrobial prescribing over the last 3 years, and then the current in the bottom line. So in 2019-20, the standard contract called for a 1% reduction in total defined daily doses, and this is expressed per 1,000 admissions. So it's the denominator reflects the activity in hospitals, and at the end of that year, 30% of trusts had met that requirement to reduce by 1%. So a very challenging requirement for trusts to achieve. And then during 2020 to 21, the standard contract was suspended for that year due to the COVID-19 pandemic. In 21-22, so the period of time relevant for the ESPAUR report, that contract was reinstated, and this time with a more challenging target of a 2% reduction in total defined daily doses per 1,000 admissions. And by the end of March 22, 50%, half of all acute hospital trusts, NHS hospital trusts, had achieved that reduction of a 2% in total prescribing per 1,000 admissions. And the current scheme that's running at the moment, and we'll be reporting on next year, the focus has changed to rather than total antibiotic prescribing, it's prescribing of antibiotics from the WHO watch and reserve categories. And an ambition was set at 4.5% reduction for this year from a baseline of 2018. And for next year, we are expecting that baseline to be aligned to the National Action Plan and to seek a further reduction to achieve a 10% reduction from the 2017 baseline, again aligning with the National Action Plan. So that scheme is live at the moment, but the focus is on the watch and reserve categories. Next slide, please. Breaking the data down for the standard contract into the regions, there is some evidence that there's differing performance from acute hospital trusts across different regions. You can see on the left-hand side, 2/3 of hospitals in the southwest region had met the standard contract of a 2% reduction in total prescribing by the end of the year, and performing less well. On the right-hand side, you can see the Midlands and the east of England. There are a number of reasons we believe that explain these challenges in performance. And from the NHS England perspective, I'm pleased to report that NHS England has invested in a regional lead for antimicrobial stewardship for each of the 7 regions of England to support hospitals with achievement against standard contract goals. Next slide, please. And just to alert you, another important improvement and assurance scheme for hospitals, of course, is the Sequence scheme, Commissioning for Quality and Innovation. And the Sequence scheme has been running for a number of years, but it was suspended for the during the COVID pandemic. And the sequence that had been planned for the 21-22 year was a sequence to incentivize the appropriate prescribing of antibiotics for adults with UTI in hospitals. So that was instead carried forward to the current year. So that this sequence for adults with UTI is currently live. And also currently live this year in 22-23 are sequence for the appropriate management of sepsis and the treatment of community-acquired pneumonia in line with the British Thoracic Society's care bundle. But on the right-hand side of the slide, you can see that there's further detail on the current sequence for UTI in adults. There are 5 processes of care that are being assessed, and trusts are expected to work towards achieving 60% of all patients who are audited, all 5 standards of care being met for those patients. And interim progress against that sequence is being reported thanks to colleagues from UKHSA, and we're posting the data on the Future NHS website. Next slide, please, Alan. And then I mentioned earlier that I would update the performance for primary care in terms of total prescribing. Similar charts. The top left chart demonstrates total prescribing per star PU in terms of items, and the bottom chart is the proportion of broad spectrum drugs. So the total prescribing at the beginning of the year was, again, 50% of integrated care boards had met the target, and that has continued to decline in terms of performance. Only 17 of the 42, so that's 40% of the integrated care boards had met the target by the end of August. So these are the most up-to-date information we have, and the performance against the proportion broad spectrum has remained high and improved slightly. So whilst the pandemic may have had an impact in terms of reduced attendances, consultations and GP practices, that activity has now returned almost to, if not exceeding, pre-pandemic levels of activity. And so we're seeing that playing through in terms of pressure to prescribe antibiotics. So there's still a lot of work to be done in the next 18 months to reach the National Action Plan goal of reducing prescribing in primary care by 25% from 2013. So across all of England, the current performance is at 0.889 items per star PU versus the National Action Plan goal of 0.871. And next slide, please, Ella. Almost out of time. Just to quickly draw your attention to a new resource that's being provided by NHS Business Service Authority colleagues in the EPAC2 dashboards very grateful to Elizabeth Beach, who was the helped design and shape this dashboard, and it's really shone a spotlight on prescribing to children, which many GP practices have found very helpful in further understanding their antibiotic prescribing. And the infographic is really quite compelling. 3 million prescriptions issued to children aged 0 to 14 in the year to November 21. Half of those prescriptions are in the younger children, aged under 5. And a really striking statistic that almost half, so 45% of children under 5 received an antibiotic in the year to November 2021. Just demonstrates how much antibiotic exposure there is in children and how much more work we need to do on that. And then final slide, please, Ella. I mentioned earlier that we have been using the Future NHS website to share data and to share updates on performance against improvement and assurance schemes and resources to support those improvement and assurance schemes. So they're all available here in the AMR program workspace in Future NHS. And as I said, open to any member of the NHS with an NHS email. And you can see the chart on the right demonstrates the use of the workspace has increased over time from launch in November last year, and sits at the moment at around about 300 site visits per month. But any further information you require on the improvement insured schemes will be there, and as well as further detail in the ESPAUR report, of course. Thank you all for your attention.
Thank you very much, Kieran, and lots of claps and hearts and different emojis for you. Thank you very much. Excellent. So we are now going to move very quickly to our Q&A section, and then we're going to have a break, because that's important that we stretch our legs and have a bit of a break. So the way we're going to go with the questions, and I'm having to use 2 devices here, so if I'm looking down, it's because I'm trying to access the question, is that the colleagues have been answering questions as they have come through, and there have been several questions and engagement in the chat, and that is absolutely, we love to see that, so please do ask us questions and continue to interact. So I'm just going to read out 1 or 2 questions per chapter, and if there is a question that you feel that hasn't been answered and you want us to answer, please repost it in the chat, and if people put a thumbs up or an emoji to it, it'll prompt me to look at that. So the first one is going to go to the colleagues in the antimicrobial resistance chapter. And it says, what awareness do we have of the reporting efficiency of carbapenemases and other notifiable diseases? Is there any plan to make this reporting as accurate as possible for real-time incidence and prevalence? Also, as per earlier, do we have any insight into source, institute, and count? So I'm looking to colleagues in the AMR chapter. I'm not sure who wants to take it, Kat or Rebecca?
Yeah, I'll take it.
Thank you, Kat.
That's fine. Rebecca can chime in if she would like as well. So kind of a couple of questions surrounding CP have come up. So this is like a bit of a mixture in response to that. So in terms of accurately capturing information on travel for international travel and that regarding patients with CPE. So the National Laboratory System, SGSS, that we use, the AMR module of that doesn't capture any information on international travel. The reference laboratory do have that as a field on one of their reference their lab referral forms. However, that's not very well completed and wouldn't be reliable if you're then looking to that to try and discern information about that. So at the moment, we can't make any, we can't discern from our national data set who has had recent international travel or not. We're looking at ways to reliably capture this information, as well as improving the national reporting of CPE outbreaks, and that will then give us more information on that. So that's something that we are looking into, particularly with because it's now been 2 years since it's been mandatory to report CPE. So it's not only looking at what we're getting through in the laboratory, it's also in trying to enhance the data quality from hospitals across the country when they're filling out their quarterly mandatory laboratory returns to find out how many screens they're doing on CPE and trying to enhance that information as well. In terms of trying to get more timely reports, so CPE, not just CPE, but all carbapenemase gram-negative bacteria are reported weekly in the NOIDS reports. So I did include a link in the chat for those, and we are currently working on auditing how carbapenemases are reported to enhance data quality within our lab SGSS as well.
Thank
I think
you,
that
Kat.
covers most of it.
That's great, excellent, and I like the combination there of a few questions together. But I know you've also been replying within the chat. Okay, so I'm going to move on to the consumption chapter, and I've got a question here. The figures as DIDs for regions are useful as antibiotic items per star PU only account for 20% of the variation, age and sex, but misses out deprivation, ethnicity, climate, etc., which partly explains the increases as you move northwards. Also in hospitals, usage as DDD per 1,000 admissions includes ambulatory antibiotics. It will be good to see DIDs at ICB levels in the future. Sabine, over to you.
Thank you. Yep, very nice. Agreed and noted on the DIDs by ICB level. We'll look into that for next year. For variations across the regions, I think geographically that's pronounced, whether looking at antibiotic usage or resistance, and within antibiotic usage, it's been published in recent years that this geographical difference it continues even after adjusting for ethnicity, deprivation, and various other differences in healthcare needs, etc. But is work that we are also going to look into further the coming year.
Thank you, Sabine.
Thanks.
Excellent. There were a few questions I noticed for the target team, and I know Donna was typing away to them. But Donna, did you want to just wrap up very quickly, just some key points of of the questions? And then I'll ask Kieran a few questions for NHS chapter, which I'll ask shortly. As you can see, colleagues, I'm bringing in other colleagues from the chapters. So this is really great, and I'm grateful for them who've been supporting within the chat. So Donna, any just overall key comments to address some of those questions that people have asked?
You just put me on the spot, Diane, because I was just typing and responding. I think that the last comment that I responded to there was basically saying that, you know, public survey data that we've got, although we're seeing, you know, prescribing rates going up, public survey data that we've got is that patients are actually wanting to know whether or not they need antibiotics. So maybe something needs to happen there about that discussion between the prescriber and the patient themselves. And we do have the target patient information leaflets that are available in HTML format to help facilitate that discussion. And there was some talk about training as well, and training in GP practices and linking it to accreditation and validation. And it was just to flag up that we are working with Kieran and the MS regional lead team to roll out the target training across each of the regions in England over the coming year, and the different regional leads are linking in with ICBs, etc., to help facilitate that rollout of training as well. And we will be evaluating that moving forward. So hopefully we can have some more information on that for you in the future. But I would be interested in talking to colleagues about linking in target with GP training and revalidation. And there was also a comment about making sure that training is spread to emergency departments and out of hours as well. So maybe that's a conversation that we can have about how to implement that as well. But as a starter, we're focusing on GP practices this year.
Thank you very much, Donna. Okay, moving on to the NHS chapter, Kieran. So colleagues would like to have an explanation of how targets are decided is one question. And I'll say the second one and then I'll repeat it again. Secondary care NHS contract. What is the carrot or stick? what happens if a trust fails to achieve their targets? So the first one is around how the targets decided, and then the second part is what happens if it fails their target. Over to you.
Thanks, Diane. I have answered these in the chat, but the targets are, at the moment, we're trying our best to align the targets with those in the National Action Plan. And the next National Action Plan is out to consultation as of today. The Department of Health and Social Care has issued a call for contributions to development of the next National Action Plan. So colleagues on the call will have the opportunity to influence whatever is decided in terms of targets for the next National Action Plan, ideally through a professional body, for example, or a group that you're a member of, rather than individual responses. But the opportunity is there for stakeholders to influence that process. In terms of internal targets within NHS England, for example, with Sequins, we try to engage with stakeholders, debate various options for targets and what level of achievement is realistic, and so we try to do it through a process of consultation with stakeholders, as well as using our judgment. And now that we have a larger team in place, there's quite a bit of experience and expertise within that team, and we work very closely with colleagues in UKHSA to understand what's possible to measure, and what the opportunities for improvement, the size of those opportunities for improvement are, what the evidence supports as being realistic as improvement goals, and working closely with colleagues in the devolved administrations as well to try and make sure that we're aligned as much as possible. In terms of the NHS standard contract, it's very much a soft power, if you like, in that there's no direct financial penalty for failing the antibiotic targets in the contract. And equally, there's no financial bonus to a hospital to achieve those targets. But having been a chief pharmacist myself and on the receiving end of difficult discussions with commissioners, it can be very uncomfortable if your organisation is failing on NHS standard contract targets, and particularly if there's a pattern of failure across a number of different areas. Then commissioners can begin to take action, and NHS England can take measures to support trusts that are seen to be failing. So I think there's a strong incentive, albeit not financial, and there's also, of course, a professional pride and a desire for trust to provide the best quality care to their patients and to celebrate that. And so having the NHS standard contract targets in place performs a very important function of keeping AMR on the radar of the trust board.
Thank you very much, Kieran. We've got 2 minutes before we need to go on a break so that colleagues can stand and stretch. There are a couple of questions coming in around what data is included. So, for example, this Community Health Trust data included, mental health trust, and then there's one for community around non-medical prescribers within the community. Is their data included? Sabine, I don't know if you are able to answer that in about 30 seconds. One thing I would say is that our methods, and I can see colleagues are posting links into the chat, very clearly articulate what is included and not included. But Sabine, if you can share it in about 30 seconds, that'll be helpful.
30 seconds. Community health services are included within the data, within the other community settings. The entire list is in the annex, as you've mentioned.
Thank you, Sabine. Okay, so it's time for a break now. I think we're about 30 seconds ahead, and we'll come back. Ella, please remind me what time we need to come back from the break.
3:20, please.
3:20. So you have about 5 minutes and 30 seconds for a break. Thank you.